Good afternoon, everybody. Welcome to another evening teaching session in the UKNG. Today we're going to have Dr. Paul Maliakal. He's one of my colleagues at Hull Royal Infirmary, and he's clinical director there, and he's one of the previous Turk chairs. And today he's going to give us a talk about the management of AVM embolisation and the joint care with neurosurgery. So thank you very much, Paul, for this evening and giving your time, and I'll hand over to you. Thank you.
Thank you, Ops, and good afternoon, everybody. So thank you for asking me to talk on the UKNG training day. That's very kind of you. So what I'm going to do today, and this is going to be mainly directed at a trainee level, and I know that there are several colleagues today who do a lot of AVM embolization work, especially in the Walton, etc. So if there are any questions, do ask me. Even if you interrupt me during the talk, that's absolutely fine. But or you can wait till the end of the talk. So as Aubrey said, I work at Hull, and I've been here for 18 years. And prior to that, I trained up in Newcastle from 2000 to 2006 with Dr. Golka. And after that, I went and spent a bit of time with Professor Lush Junius in Paris. And that was a very interesting time, especially to learn about AVM work, etc. So I was lucky to have worked with excellent interventionists. What I'm going to share today is predominantly what I've experienced as an interventionist over the last 2 decades or so in training and 18 years as a consultant. This may not be exactly what you guys do in your own centers, but obviously, we can discuss all about that. Okay, so you would all agree that our aim in treating a patient with brain AVM is to get them through safely through their life, i.e. prevent a bleed from it. Now, those of you who are aware of Aruba trial, they started recruiting in 2007 and stopped the recruitment in 2013 because according to their statistical model, it was felt that doing nothing was far better and far safer than doing something. Now, the very fact that you're attending today's talk means that you're probably in this group who prefer to do endovascular embolization and also work with people who do the other options of treatment. Now, so most surgeons, when I spoke to the surgeons at Cambridge at the BNVG, they were all the opinion, many of them were of the opinion that let's operate on them. Now, when I speak to Matt Radatz, my colleague from Sheffield, his opinion would be let's zap it. And then, many of my colleagues who work in high volume AVM centers would say, let's glue it, whether it's in one session or in multiple sessions, that's the center, center's preference. Over the years, I've got to learn that I think the safest approach would be a pragmatic combination of 3 treatment options. And that's a personal opinion. And
Hi, Paul, you just
Paul, you're muted. Paul, you're muted.
Sorry, Paul, we can't hear you.
You're muted from Teams. You were unmuted just now.
Okay, can you hear me now?
Yes,
yeah, we can hear you now.
Thank you.
Yeah.
Thanks.
I've no idea what happened there. I just got muted. Don't know what happened. Sorry about that. Okay, so I'll go through a little bit of history mainly for the trainees. So when I looked at literature before I spoke to surgeons, the first recorded embolization was in 1960. When they introduced glue-coated steel spheres. I mean, it sounds terrifying, and they injected directly into an artery supplying an AVM. But Serbenenko is the name that most of us are familiar with because he was the first one who did a balloon embolization of an aneurysm. And I think he used the same sort of methods for AVM embolization as well, this time using detachable balloons. And this was the very first case report using these flow-directed steel spheres. So all of these techniques depended very heavily on the greater degree of blood flow towards an AVM. We know it happens, but they relied on that and pray, I think most of them were praying when they released whatever embolic agent they released into the artery so that it will end up in a AVM nidus and nowhere else. So it would, I can't find any descriptions of the complication rates, but you can imagine what those complication rates would be. Now, modern techniques, Kerber is the first one to have utilized a microcatheter with a calibrated leak balloon. We don't use those sort of things anymore. And the first liquid embolic agent that he used was isobutyl 2-cyanoacrylate, otherwise known as superglue. And we still use, to this day, we use variations of superglue in our practice, some centers more than the others. And then along the way, over the last 20 plus years, we've had a very significant improvements in microcatheter design, and that's complemented by better access catheters, intermediate catheters that can go all the way to an AVM almost. And these sort of things were not available when I was training, and we're in a very fortunate position to make things happen in a more safe manner. So what are the types of scenarios where we utilize our ability as an interventional group to do embolizations and AVMs? Now, for quite a bit of my time, I practiced curative embolization. And my practice was entirely based on what I was taught in Newcastle by Dr. Golka and his team and the surgical colleagues over there. They tended to agree on some of the AVMs be treated purely with endovascular treatment. And my boss, Dr. Golka, who many of you know, did curative embolizations, but staged them. And he took out, say, 25–30% in one go, and then he would bring the patient back after 4 or 6 weeks and do it again, much the same as what Hans Nasser used to do. Rarely they used to do a combined procedure. So he would do the embolization, and the surgeons, Prof. Mendelow or Alistair Jenkins, would take that patient to theatre on a subsequent day, very rarely on the same day. I can recall just one time in about 3 years I was there. These days, that practice has changed quite a bit, but that's based on a number of experiences, some of them very negative. So it would be good to share that sort of negative experiences of outcome, because for very many talks that you go to, you will only hear the best outcomes, and may not get a share of the problems that interventionists face on a daily basis. The second group where we utilize embolization is the targeted one. So these are the patients who have AVMs, who have bled or have what looks like a high-risk lesion, and you target that particular part of the nidus and get rid of it, and hoping that you would reduce risk of further hemorrhage or make it a bit safer. But that obviously runs the risk of rerouting blood flow within the nidus, and which in itself is a risk. Pre-microsurgical resection. This is something that we've done quite a bit over the last 8 years or so, and this is the one that I'll be concentrating on towards the end of my talk. Pre-SDRs. Now, if you talk to colleagues in Sheffield, especially the neurosurgical colleagues, this is something that they do not like, because very many of our colleagues refer patients to Sheffield with patch embolized AVM. If you were successful in taking out, say, huge chunk of it, say 60 or 70% of it, but all in one part of the nidus, or a contiguous part of the nidus, and not leave, you know, kind of patchy areas unembolized, then that's beneficial to them. But even amongst what appears to be fully embolized part of the nidus, there always lurks, you know, patent areas of nidus. So therefore, they do not like it. And there have been very, very rare occasions when I was asked to embolize and reduce something from, say, 6 centimeters to a smaller volume that they could then treat with STRs. And I'll show you those examples. So just thinking of our UK-wide practice, it varies greatly. And you all know, you know, how your centers approach treatment of a patient with AVM. The utilization of techniques, embolic agents, microcatheters, and the intra and post-procedure care, so everything varies between centers. And this is something that our community has tried to harmonize between centers, but never been able to. And the other factor is that there is very little cooperation between our community and the neurosurgical community when it comes to AVM management. There are some exceptions, of course. Some centers always aim for curative treatment in a very aggressive fashion. Some of them do multiple catheters and target the AVM in one session. Some do multiple sessions and be careful about how much they take out of the AVM nidus. Some are more aggressive. They might try and get a big AVM sorted in 1 or 2 sessions. Some centers don't do any. Some do only targeted embolization, as I've described. Some do pre-surgical embolization, and some do that pre-surgical embolization on the same day under the same anesthetic. And the obvious risk there is that if you do embolization and then wake the patient up, you are exposing that patient to rerouting of pressure, rerouting of flow, and very wide variations when the patient extubates. And that has led to disaster. And I have burned my fingers there, so I know I'll share that experience in a bit. In short, many of us work in a silo mentality within our own little worlds. And we think what we do is the best. And that may not be the case. Now, we enjoy a lot of wonderful devices and embolic agents. You know, at the time of, you know, when I was training, we only had, you know, Magic as an amazing catheter that had come into the market, obviously created by Bolt. And I had the privilege of running into a gentleman called Leopold Plavinsky. He was the engineer who made the Magic catheter. And when our French colleagues who, you know, used them in Paris, one of them said Magic, and therefore the name stuck, Magic. And he was an amazing guy. He told me about how we developed, you know, the extrusion techniques to make these catheters. And then since then, things have evolved greatly. Now we have detachable tip catheters or the lizard's tail catheters. So Sonic is our mainstay. I have tried Apollo in the past, but I just prefer Sonic. And I find them far more trackable over a wire. And also the soft tip technique. So you take the wire, but not fully into the tip of the catheter, but that's enough to support the catheter to glide through the vessel. So I call it a soft tip technique. Those of you who've grown up in the tropics and seen lizards and been, you know, as children chased after the lizards, know that they leave their tails behind and run. And that's exactly what we try to achieve with Sonic and Apollo catheters. There are other modifications, such as the balloon-tipped microcatheter, which I am not a big fan of, because I think that it runs the risk of, you know, the embolic agent coming proximal to the balloon, and there's always a risk of rupture of the artery. So for those reasons, I tend not to. Wide variety of embolic agents. Fill is currently off shelf, but I believe later this year it will come back. Glue has been around for a very long time, and depending on what modifications you apply to the original super glue, you can delay polymerization. And then obviously the other major factor in delaying polymerization is how much you dilute it. So we use glue from 67% in dissecting aneurysms or fast flow AVMs or fistulae to 5% in meningiomas. So a very wide range of dilutions. And the variety of glue we use is glue brand 2. And I find that the difference between histoacryl and this is that the polymerization is slightly slower, and therefore it gives you just a little bit more breathing space. Moving on, we talked about access catheter technology, etc. So we routinely use triaxial systems, and we'll get the intermediate catheter as close to the feeding artery as possible, because this helps not just in getting to the nidus, but more importantly, in retrieval of the microcatheter. If you were to have substantial distance between the tip of your microcatheter, whether it's Sonic or Magic or any others, and your intermediate catheter, when you pull, it puts an undue pressure on the artery, in the intervening artery. And therefore, it is always worthwhile getting an intermediate catheter to a position of stability as close as possible. Okay. We've kind of briefly mentioned all of these, and the addition is headway geo, which is capable of, you can deliver coils through it as well, and is compatible with DMSO. Now, in addition to liquid embolics, we use platinum coils quite a lot, especially in very large AVMs, and especially when there are multiple feeders into a nidus, and you think, what's the best way to skin this AVM? For me, I tend to kind of block off multiple inflows and then concentrate on one crucial one. It doesn't have to be necessarily the largest one, but a crucial one that gets me, when I've blocked off, say, 3 or 4 different branches, then I'm left with one which can concentrate on just getting the liquid embolic through and effect a good blockage of the nidus, and then subsequently the vein. So platinum coils help in slowing down that flow, especially in big arteries, and I'll show you examples. Histoacryl, glue brand, and then for many years I used onyx. And I did encounter many issues with it, especially with the tantalum powder. So the micronized tantalum powder is supposed to be well in solution once you pre-agitate it, but sadly, it doesn't always stay in solution. It tends to clump quite a bit. And then when you're faced with feeling resistance to your injection, and you feel it in your fingertips more than you see on the screen, then you realize you're kind of confused as to whether what you're feeling is the clump of tantalum, or is it just the nidus filling up and therefore you're feeling the back pressure. You're not entirely certain. So I tend to avoid anything with tantalum in. That's a personal opinion and experience. There's another reason why there may be a little bit of difference between the ones, liquid embolics that contain tantalum powder versus other ones. And I'll show you a little paper from René Chapeau. Of late, I've been a big fan of precipitating hydrophobic injectable liquid, otherwise known as fill, from Microvention. And one of the other reasons why we avoid this tantalum-containing agents in pre-surgical patients, and these days majority of patients are pre-surgical patients, is that monopolar cauteries can spark, and I've seen it happen in the early days when I was using onyx. I would go up to theatre and I would see my surgical colleagues, enjoying a little bit of sparking, being entertained by it. But if you use bipolar cauteries, you don't tend to see that very much. Okay, but I don't see them very much these days because we are using more of fill and glue. The paper I was mentioning was this, the one from René Chapeau. Now, if you look at the flow of tantalum-containing liquid embolics in an artery, you see that proximally, it may fill all of the lumen of the artery, but distally, it tends to spread along the wall, along the side, along the wall of the thing. So you may end up with areas that are not filled. The lumen is not completely occluded. But whereas the ones that do not contain tantalum tend to progress more evenly as a column, and that is one of the reasons. I personally think that there is better penetration when you have a tantalum-free agent. But once again, it's a personal opinion. Now, we briefly talked about what we try and achieve from embolization. If it's a curative one, then it is perhaps best that you have cooperation from your ICU colleagues and your anesthetic colleagues in making sure that there are no huge variations in blood pressure, especially during the procedure, and very crucially in the post-procedure, just peri-procedure time when they wake up. Now, that there are centers in Europe where patients are kept asleep even after routine embolizations for periods of time. It can vary from 24 hours to 48 hours, etc. I only have experience of transarterial management of brain AVMs and no experience of transvenous at all. So I wouldn't dare comment on any of that. I know Walton has quite a lot of experience over there with Mani and other colleagues. But I do have some transvenous experience with fistulae. We have done coil embolizations and block off the fistula points transvenously. But AVMs I do not, so I don't want to comment on that. So when the few times that I've done single sessions, I think I've got away with without too many problems. But multiple session treatments, once or twice, I've got into trouble, especially in that peri-procedural time when patients wake up in the hands of anesthetists who are probably not too well versed in managing patients with AVM, and they're not too worried about the blood pressure control. So despite us raising our concerns during the brief, during the procedure, and afterwards, sometimes with the best will in the world, the blood pressure control slips, and the end results are terrible because I've had two patients who had devastating bleeds, both being fatal. So let's look at some examples of curative embolization. So this is a reasonably nice case to do because you have a big artery coming into a relatively compact nidus, a single vein drainage, and there is quite a bit of length for that vein to get to the dural venous sinus. So you have a certain length where you can allow the embolic to get through. And you can see that after stage 1 of the embolization, quite a bit of the nidus has been taken, and a further embolization has completely taken the nidus and the vein. Now, if you get this wrong and you embolize too fast and you push more glue or liquid embolic, any other liquid embolic into the vein, then that will be disastrous because the rerouting and the increased pressure within the nidus or residual nidus will cause rupture, especially if the blood pressure is not strictly controlled. Now, let's look at some of the other examples, more tricky ones. So this is the young guy with an acute bleed affecting a very eloquent area, and he does have right hemiplasia. The surgeons were very reluctant to approach it. You can see that the culprit, which is a tiny aneurysm, is actually quite deep. For them to get to it, they'll have to decompress this hematoma, and you know what happens when you decompress certain hematomas, the aneurysms can rebleed, and therefore they were very reluctant to address this acutely. Given the age of the patient, we decided that we should give him a chance, in that we knew that the real trouble, the real risk is that dissecting aneurysm there, which is down there. It's very distal, and you know that our routine catheters of the length of 165 centimeters will never get there. Fortunately, we had a 190 centimeter long sonic catheter available to us, and you can see that it's gone all the way anteriorly and then tracked all the way back to the dissecting aneurysm, and I put a drop of glue there, obviously 67% and not anything smaller than that. And we achieved what we set out to do. You can see that aneurysm is no longer visible there. And he made a good recovery. We sent it for STRS, and this is the remaining cleft of the hematoma, much smaller than what it used to be. Good recovery, but he refused to come for further angiographic follow-up, so we had to make do with MRA, but he's still doing well after many, many years. Now, going to a larger aneurysm, and also in a very young patient, 17-year-old lady. When she first came in, she was in a severely compromised state, comatose, ventilated, and you can see on the CT angiogram that there are residual AVM, especially to the medial aspect of the large hematoma. She had some mass effect, but the surgeons are very reluctant to go in. So you look at the AVM, this is not a pretty AVM because it's diffuse and is supplied by multiple branches going into the temporal area, all from the metacerebral artery. You can see that, so multiple things. Now, our plan was, we'll do the best for this young patient, give her a chance rather than leave her and see, what fate brings away. So we set out on treating her, and those days I was using Onyx, and you can see that the Onyx cast is really dense, but the phenomenon we were talking about, that the partial filling of some of the arteries, you could perhaps see that happen here, not fully taken out. But at the end of the procedure, we managed to get a relatively solid cast with multiple embolizations of using Onyx and glue brown, and that was the end result. So those vessels that were coming down were gone, and the draining vein, which was lying across here, was no longer seen. So we were delighted with what we achieved. And this was the first follow-up. Nothing very obvious here, but in the second follow-up on the MR, you can see that there is now a nidus. In retrospect, you look at this vein here, which is not seen on the right side, you could actually see the vein lower down. So it was present and it wasn't seen very well on the other side. So there was a symmetry that we should have picked up on. But that, within a nidus that contains Onyx, MRA is going to struggle to identify that residual nidus, especially if it is small and diffuse. Nevertheless, she had a recurrence. That was confirmed on angiography, and you can now begin to see that vein fill and then connect to the labia going posteriorly. So at this stage, there was no real option of embolization, further embolization, because this is, Sheffield colleagues' worst nightmare. And I contributed to that nightmare too, giving them this particular patient. In any case, they managed to kind of zap the whole thing. So they didn't leave any areas, they zapped the whole thing, and thankfully, eventually it was cured. Okay. Now, another very interesting one was this young chap, once again, came in with a rupture. You can see that the blood is predominantly in the right cerebellopontine angle, and the culprit was this dissecting aneurysm arising from the ICA. And so selective embolization of that particular branch with glue, and we took out that offending course and then sent him for STRS. And interestingly, this guy had most of the aneurysm, the AVM seemed to have gone, but when we injected the external carotid artery, we found a funny superior petrosus sinus fistula with a venous aneurysm. Now, I'm not entirely convinced whether, this was a kind of a peripheral supply to the AVM, or was this a coincidental abnormality. In any case, there was no way we could embolize it, so our surgical colleagues actually operated on him and clipped the fistula. And that's quite a difficult approach, knowing that it's in a superior petrosa region. Another difficult one are pregnant patients with, pregnant patients presenting with AVM bleeds. We know that this happens, especially with the hyperdynamic circulation. And this patient, a young lady, 18 weeks pregnant, the circulation is just about turning hyperdynamic. It gets more hyperdynamic as the pregnancy proceeds. And here we have a choroidal AVM. And those are nasty things to begin with. And when in a pregnant stage, even more dangerous and more risk of rebleed because of the hyperdynamic circulation. So we had a very comprehensive debate between all the relevant specialties. We spoke to colleagues in Cambridge because at that time, the only center to have published any publication worthy of note was Cambridge, because they had about 3 patients that they kind of gathered with it from the experience. And I spoke to Rick Intervedi, and then we came up with a plan that we would, very carefully, without exposing the fetus to too much radiation, do an angio and identify if there is a target to take out, and then let it complete a pregnancy and then go on to STRs at some point. And when you look at the conventional runs, you look at this AVM, it's a diffuse, nasty looking thing. And that you would expect it from choroidal AVMs. But when you do very selective runs, you begin to see that there are, within the nidus, there are culprits. And the culprit in this case was an idland here. So this is a sonic catheter, pretty close to, and as close to I can get to, because you can now see that the caliber of this microcatheter is the same as the caliber of the artery. And so we can't actually proceed any further. So we took a pot shot from there, occluded the aneurysm. So we knew we had taken out what appeared to be the main culprit, but sometimes you get too confident and maybe, to be an opportunist. So here you can see this distal branch here has a parenchymal branch going to the occipital cortex. This is this very, very small AVM branch, which looked rather chunky to me and magnified. So I thought maybe, take the opportunity and just get into it and occlude it. So this is my catheter tip just into that branch. That's the furthest I could get to. And I prepared the catheter. Now, many of you know that these catheters are very flimsy, and they sometimes are not very stable. And by the time I prepared the catheter and started the injection, you can see that the catheter had migrated proximally. So unfortunately, at the onset of the glue injection, it pushed the microcatheter back. And the end result is that very, very small amount of glue went into that parenchymal branch. End result, from an AVM perspective, looks reasonable, but we know that there is an issue here. So she woke up reasonably okay. You can see the bit of remnant of AVM here, but more importantly, you can see a occipital lobe infarct. Thankfully, it only led to a minimal, less than quadrantinopic defect, and thankfully she got better and back to driving, etc. So I was lucky there, and that taught me a lesson. Stick to what you want to achieve with a reasonable level of risk, and don't go beyond it. Now, I was talking about the pre-STRS embolizations. We don't do these very often, but this gentleman had a very large AVM, and in this diameter, it was over 6 centimeters. And you can see that even the transverse diameter is close to 4 centimeters. So this is a nightmare for the surgeons and for the radiosurgeons. So our plan was to reduce the nidus to a certain size that would then be amenable to radiosurgery. And that's what we set about to do. So I did 3 separate embolizations, and you can see that there were huge supplies from anti-cerebrals bilaterally, and there were a lot of, these are the awful posterior circulation ones, and then a few MCA circulation ones as well coming posterior laterally. So we, in 3 embolizations, we used a combination of coils, glue, etc., and got rid of the vast, I would say probably about 70 to 80% of that AVM. What was left behind was the ones supplied by the choroidal branches and those very, very distal MCA branches. And this patient then went on to Sheffield for STRs, and thankfully we managed to get a complete obliteration. So this is what we concentrate on, and I'll tell you why we now do what we do as our routine practice, which is embolize and take out the AVM in the same sitting without waking the patient up. So our aim is to do it safely and safely reduce the nidal volume, especially the deep feeders, which the surgeons find more difficult to tackle. The superficial ones that they come across, it's easy for them to tackle, but the deeper ones we selectively take out for them. And we secure the fistulous components. Once again, a problem for surgeons, or any troublesome aneurysms. We have to take care that we do not occlude the draining vein, because when that happens, it is invariably a disaster, as I would show in the next case. So, middle-aged man with a lovely family. I'll never forget this family or this patient, because as you know, when you get such an outcome, you live with it forever. You never forget some of these disasters that you face. So we gave him all the options, and he decided to undergo embolisation surgery. And this is pre-2016, so about 9 years ago. And he opted for embolisation, and then followed by surgery a few days later. Now you can see that is the temporal lobe AVM, okay? And we set about to do the embolisation here, and there are multiple branches coming in. So I took out a reasonable chunk of it. I would say probably 60 or 70%. And there were 3 major veins draining. One was the one going inferiorly, the other one is going posteriorly, and the other one is going superiorly. So at the end of the procedure, this is what I left behind. We had maintained low pressure, etc., but we knew that one of those veins had gone. So we were very cautious, in maintaining his low blood pressure. But this is what happened. This is after the patient woke up in recovery. He was talking to me about the procedure, and I was explaining everything. And later on, he had a severe left-sided headache, and eventually, despite the valiant efforts of my surgical colleagues through the night, unfortunately, he passed away. So that was the index case that led a change in our practice. And, we couldn't have proceeded from that event without changing the way we treat the patients. Now, if you look at, we have a fair idea that the risk associated with an AVM embolization is definitely in double digits. It's well over 10 for majority of practitioners in the UK and abroad. One of the best resources we have is the Japanese registry. So they looked at over 4 years, over 100 institutions. They're looking at over 1,000 procedures. So that's a good number to look at. And they have a variety of different reasons why they performed them. So pre-surgical, there were pre-radiosurgical, and sole endovascular treatment, much the same as the practice that I have done for a good number of years of my practice. And you can see that the success rates were about 1/3. So which means in all these procedures, you couldn't achieve complete embolization in 2/3 of patients. And worse still, we're looking at 13% complications. And that is a large enough study. And Japanese, the ones I've come across, are fantastic practitioners. I envy the techniques and the way they work, etc. And therefore, I can take this data as something that is reasonably concrete. Okay, so complications do happen. And you look at any other meta-analysis, and you would see that it can vary between 5 to 15%. So And when you look at these other trials, studies, Taylor, Hartman, etc., we're looking at double digits once again. Now, we wouldn't accept the same for aneurysm, will we? Certainly not. We now talk to patients that our risk for aneurysm treatment is 3%. So what can we do to minimize this risk and bring down that risk from double digits to single digits? So if you think about, sometimes you can get embolic events like what I showed earlier, but our biggest enemy is hemorrhage, either inter-procedure or more likely peri-procedure. So at what points do we put that patient at risk, and with what kind of treatment? So if you embolize part of the AVM, you then put the patient at risk of intranidal rerouting of blood pressure. Understandable, more blood pressure, is distributed. Sometimes if you take out a whole artery, then the other arteries reroute the blood pressure and then puts nidus the same risk. Occlusion of draining veins with glue prior to AVM nidus being taken off fully, and we've been at the receiving end of this problem. Delayed thrombosis does happen, and I suspect this is probably what happened in my patient's case as well. The other two veins probably, blocked off as well. Excessively high injection pressures, and that makes real sense, because if you do it too fast and with too much pressure, of course you can burst an AVM. So the conclusion from this trial was, or this particular study, which is largely hypothetical, is that if you induce hypotension during and after, you can avoid some of these problems. Not the problems with veins, not problems 3, 4, and 5, but 1 and 2. And when another study looked at, intraprocedural or peri-procedural ruptures, they found that if people devascularize more than 40% of a nidus, it put them at risk of a rupture. So their suggestion was that if you are a center that does staged embolizations of AVMs, then take out only up to 30%, and then certainly practice a 20% reduction from baseline MAP. And some people obviously keep the patients asleep for 1 or 2 days, depending on local practice. So having talked about all this, having shown you some good results and some terrible results, I now probably want to bring your thoughts down to what I've just put down here, a little step ladder. For many people, complications happen, including me, for the majority of my time, and complications happen during a procedure or immediately post-procedure. But, having been, involved in all of this for 2 decades, I think now many of the procedures, complications actually started way before in deciding to treat, and our plans, pre-procedure plans, etc. This is where I think, especially when it comes to management of AVMs, I think this is where we need to give it the most thought, rather than worrying about what happens during the procedure stage, because by then it's a bit too late. So between 2016 and 2018, we looked at some of our experience, about 19 patients. And Daniel Brown, who's a consultant neurosurgeon at Cambridge now, works with Riggin Trivedi and that particular group, who has quite a substantial experience of AVM surgery. And he wrote this paper for us based on our experience. And we found that when we did same-day embolizations and microsurgical resection straight from embolization to surgery, the surgeons clearly found it very beneficial, because the blood loss was less, time for the procedure was less, and the complication rates were significantly less. So I wish we'll have another bite at looking at this experience again, now that we've accrued many more patients over the last few years doing the same. And we know the anecdotal evidence is that we are quite happy with the pattern we follow. So how do we decide, what's the best way to treat AVMs? For me, what I've learned is that if you do things in a collaborative manner and be open with the patient and tell the patient all options, because I know that certain centers only emphasize what they think is best and what their center is best at. But I'm not of that opinion, and I think I've learned my lessons to be of that thought process or the way of thinking now. And at the end of the day, and this is something I stress to all our trainees here and to my colleagues, that you won't make a mistake if you choose for yourself what you would offer that patient, or rather you would offer that patient, other way around, sorry, offer the patient what you would want for yourself. It's the same as asking 100 neurosurgeons, whether you have your aneurysm clipped or coiled, and you can tell, almost certainly the answer would be, they'll all want their aneurysms coiled by a good colleague. So with that, I think I'll conclude. Thank you all.
Thank you very much, Paul. That's a fantastic talk. Thank you for showing all those cases as well. Does anybody, I'll just open to the floor. Does anybody have any questions to ask Paul whilst we've got him here?
I mean, Richard might be able to kind of give us a glimpse of what they do at the Walton. Richard, I mean, your experience. If you're talking, Richard, we can't hear you.
Sorry, can you hear me now?
Yeah, I can hear you.
Yeah.
We can hear you now. Yeah.
So we've been doing now. So we've been doing a combination of both. I am involved in to be fair, full disclaimer, I'm involved in a minority of them. Mostly, it's my colleagues, Dr. Maliakal and Dr. Chandran, who do the large complex ones. We tend to use a glue plug technique where we use a detachable catheter, and we tend to prefer more the Apollo from our end. But you're right, the Sonic tracks much better. We've had a few disasters with the Sonic where the catheter detached prematurely, so we ended up going for more. We prefer the Apollo, and essentially the technique that we use is essentially get the Apollo, use a magic, the detachable point, and deploy multiple spiff coils, which currently they are in short supply. They have a problem in sourcing one of the materials apparently, and then use 50% glue to create a plug, and then just inject. And we try if possible to use a multi-plug technique. We have always emphasized, so our go-to is that we are usually more than one person. We're usually two consultants working on the case, on these cases, and that is essentially it. I think in terms of the venous cases, same thing. We rarely do a purely venous case, in the sense we tend to do arterial and venous most of the times, a combination of both. What we sometimes do in a multi-staged approach is that we tend to go for the arterials. So we'll use a multi-stage approach doing arterial embolization, and then at the end go for venous. And I mean, till now it's worked relatively well. We've had the same disasters that you mentioned, Paul, about maintaining blood pressure, and the importance of that, and being very disciplined about it. So we've had a few cases where for whatever reason blood pressure was lost, and it's very distressing for as an interventionist, because patient wakes up fine. They're speaking to you, they're talking to, and then literally a few hours, or in a few cases, we had one case where 2 to 3 days after, just there was a massive bleed. So that is essentially, in terms of our practice, what we've been doing. I think our neurosurgeons have been more accommodating with us. I think. That being said, whereas before we were much more endovascularly aggressive, we are being a bit more cognizant of, listen, in certain cases where, listen, there is SRS, because one of the things about SRS is sort of the argument that we bring is that whereas we are minimally invasive, they are, in inverted commas, not invasive at all. You don't puncture that. So patients obviously love that, and like you said, I think a lot of the decision making at the start. That I think plays an important role. Managing, and it plays an important role managing patient expectations and your own expectations as well. So yeah, that is essentially to summarize sort of from our end.
No, thank you, Richard. Thank you for sharing that. I mean, that's very kind. Yeah.
Amrit.
In the acute phase when they've bled, what's your sort of timescale for treating them, from sort of point of CTA, and when would you advise doing a diagnostic catheter, and when do you proceed to treatment?
So the answer to that is, if the CTA suggests that there is a danger point, for example, a nodal aneurysm or a venous aneurysm, or anything that looks like a vulnerable point where the bleeding has happened from, then we would target it more quickly. That is, so targeted embolization is what we would do. So in order to make that happen, obviously you have to angio them quicker than, rather than leave them for 6 or 8 weeks. So that's what I would say. So if there is the nodal aneurysm, if there's a pre-nodal aneurysm or venous aneurysms you think are the culprits, then address them soon rather than later.
Okay, so if there's a target for embolization acutely, then target that, and if not, then sort of in a delayed fashion, because the bleeds alter the morphology a bit. Is that right?
Indeed. Yeah, they do. Yeah.
And then you would do that sort of in the next 2-3 months, or in a delayed.
We leave it for we routinely leave it for 6 to 8 weeks for the hematoma to get smaller. Yeah. But on the other hand, so the last one we did was last Wednesday. So there was a patient with a posterior fossa bleed, quite a substantial bleed from a dissecting aneurysm of the pica, one of the pica branches supplying a peripheral AVM. So we selectively took out that superior branch and part of the AVM. The rest of the AVM looked like it was just, the run-of-the-mill nidus. And so therefore we haven't touched it. So when he recovers, we'll send him to Sheffield. Your way.
Thank you.
Just to continue exactly what Paul said, and that has been our practice as well. We, in the acute phase, unless we see like a bleed from a flow aneurysm or that we can tackle, then we go for it. If not, we usually wait. We wait for the hematoma. We've burnt our fingers where we have been too aggressive at the start. You go in guns blazing, try and obliterate the whole AVM, and then you realize later on that there's more because the hematoma itself has is actually compressing the AVM. Paul, just a question. I was always I've had like 1 or 2 cases where you're not entirely sure whether it is there's a flow aneurysm which is very close, but you're not entirely sure whether it is the AVM or the flow aneurysm that that is bleeding, that is the bleeding point. Now, I've been told, like I asked Professor Chapeau about that. He has always meant he's very adamant that if you just obliterate the AVM, then the risks of the flow aneurysm automatically disappear. I have always been a bit uneasy with that, because it is in sense I would prefer if I can take both at the same time, but obviously then you risk obviously obliterating more pile vessels, then and you get a larger associated infarct with that. I don't know, what is your experience in that?
So if the flow aneurysms are, I mean, look, let's start with the plain CT. So if the hemorrhage is very diffuse and not really appearing as a hematoma related to the AVM nidus itself, then obviously that points to the source of the bleeding being something else. And often that would point more towards the flow aneurysm rather than a nidal hematoma or whatever. So if it's a diffuse one, the aneurysm has to be taken out. There's no doubt about it. You have to take it out. And more often than not, the aneurysms that we encounter as flow aneurysms are dissecting aneurysms, especially that of the pica. So choroidal arteries and the pica, you encounter the most number of dissecting aneurysms. Taking the pica branches out is very safe. And, I've taken out many of them, and the patients have never suffered any significant infarction of any sort. But choroidal arteries, they are a different ballgame, because if you are not absolutely on the point of the AVM, you run and even if you get reflux, you then risk the basic ganglia.
Yeah.
And that's a different ballgame altogether. So different level of risk between pica related aneurysms and choroidal artery related aneurysms. So so simple answer is, if the hemorrhage is very diffuse and you see a flow aneurysm, I would certainly take it out.
Okay. Nice. Yeah. Thanks. Thank you. Makes sense.
Okay. Any other questions at all? Okay. Well, thank you very much, Paul.
Thank you, Paul. Much appreciated. Thank you.
Pleasure, and good luck to all the young trainees. We'll see you around at some point. Bye-bye.
Thank you so much, Dr. Maliakal. Thank you so much for this.
Thank you very much, everybody. Have a good evening.
Thank you.
Thank you.
Bye.
Bye-bye.